Hello, I am Shafir Rahman, and today we are going to discuss about myeloproliferative disorders. So myeloproliferative disorders are basically disorders of myeloid proliferation. So as we have discussed in our previous podcasts that basically hematopoietic stem cells has two fates. Either it will have to go towards the myeloid cell lineage or it will have to go towards the lymphoid cell lineage. So myeloproliferative disorders is basically the disorder of myeloid stem lineage in which there is proliferation of the myeloid stem cells, and hence it can lead towards increased granulocytes, red blood cells, or platelets. So in this disorder what happens that there is proliferation of these cell lineages, and we will always found increased peripheral cell counts of either granulocytes, red blood cells, or platelets. So we had discussed in our previous podcast about the chronic myeloid leukemia, in which there were an increase in granulocytes. The most important granulocytes, if you remember from my previous podcast, was the basophil, which is characteristic of chronic myeloid leukemia. Then when there is an increase in platelet count, we will say that disorder has essential thrombocytosis. And when there is an increase in the red blood cells, we will say that it is polycythemia vera. So myeloproliferative disorders are subdivided into the four major categories. One of it is the chronic myeloid leukemia, in which there is increase in granulocytes. The second one is the essential thrombocytosis, where there is an increase in platelet count. The third is polycythemia vera, where there is an increase in number of red blood cells. And the fourth one is myelofibrosis, in which you will find that the bone marrow turn fibrotic, and the cells, instead of getting increase in number, you will see there will be the decrease in count of the cell lineages, and we will discuss that in detail, that what is basically myelofibrosis. Now if we can see the genetic makeup of these diseases, so you will find out that the chronic myelogenous leukemia is basically associated with that Philadelphia chromosome, and there was a translocation of 922 with the fusion of PCR and ABL gene. Rest of the myeloproliferative disorders like polycythemia vera, essential thrombocytosis, and myelofibrosis are usually associated with JAK2 mutations. So what will happen in the JAK2 mutation? That JAK2 is basically like a gene for cytoplasmic tyrosine kinase present on the chromosome number 9. So what is JAK2? It's a gene for cytoplasmic tyrosine kinase and present on the chromosome number 9. Now when there will be the mutation of the JAK2, what will happen? That there will be increase in tyrosine phosphorylation, because kinase function is to phosphorylate the enzyme. So when there will be a mutation, you will find out that there will be increase in tyrosine phosphorylation. So what will be the end result of that phosphorylation? That the progenitor cells will become hypersensitive to cytokines and will start grow and have increased survival time, and we will say that it will become increased in number, having increase in survival, more growth, and hence a sort of neoplasia. So if we can see the polycythemia vera, it's basically defined as elevated red blood cell mass. So if you can recall from hematology initial lessons that red blood cell mass cannot be measured, and we have to always use surrogate markers like hemoglobin and hematocrit to measure red blood cell mass. So the normal hemoglobin in gram per deciliter is 15. You can say yes, there is variation between men and women, and there is a range, but generally speaking, almost that 15 number is a average number of the hemoglobin both in male and female. Hematocrit, let us say it's a 45 in percentage. So what will happen that in polycythemia vera, the hemoglobin count will be increased maybe up to 20. Hematocrit will increase maybe from 45 towards 60. So it will be a disorder which we will call having elevated red blood cell mass measured by hemoglobin and hematocrit. So when polycythemia vera will cause increase in number of red blood cells, So what you have to expect is that erythropoietin levels should drop in the blood, because you don't need red blood cells anymore, because there are already sufficient supply in the body. So the EPO level, erythropoietin level, which is secreted by the peritubular cells in the kidney, has to be reduced. So first thing in polycythemia vera, you have to differentiate between those diseases which are having high erythropoietin level versus those diseases in which there is low erythropoietin level, which is a true polycythemia vera. So if you are having, let's suppose, lung disease in which there is a chronic hypoxia, so in chronic hypoxia you will always have that increase in erythropoietin levels, because the peritubular cells of the kidney will secrete the erythropoietin, so that bone marrow will stimulate the production of the red blood cells. Similarly, there are also like erythropoietin secreting tumors like renal cell carcinoma most commonly, and hepatocellular carcinoma can also increase the erythropoietin levels. So when these levels are increased, so again you can find increase in red blood cell count. So you have to differentiate between the primary polycythemia vera, that polycythemia vera having increased red blood cells, increased count in red blood cells with decrease in erythropoietin level. So for that purpose you have to see the partial pressure of the oxygen and erythropoietin level in the blood. So if it is a hypoxia or hypoxic state, for example in lung disease, what you will find that the partial pressure of oxygen will be dropped, but when it will be dropped, erythropoietin level will be increased. Renal cell carcinoma, hepatocellular carcinoma, you will find out that the partial pressure of oxygens will be normal. However, in those disorders, even though partial pressure of oxygen is normal, you will find increase in erythropoietin levels. However, in polycythemia vera, the most interesting situation is that partial pressure of oxygen will be normal, because this partial pressure of oxygen has to be normal in polycythemia vera, because red blood cells are increased in number, but they are not deformed, or there is no any such type of pathology in which there is disruption of the oxygen saturation of hemoglobin curve, and erythropoietin level will be decreased in the polycythemia vera. So in that way you can diagnose the polycythemia vera, which is a myeloproliferative disorder. So what will happen, that there will be increase in red blood cell mass, and when red blood cell mass is increased, it leads to increase in blood volume. So you can expect hypertension and flushing in these patients. Then again, there is increase in viscosity of blood because of increase in red blood cells in the blood. So you can also expect thrombosis in this polycythemia vera. So many patients are asymptomatic in the polycythemia vera. On the routine CBC, you will find out that their red blood cell or hemoglobin count is increased. So they are usually asymptomatic, but many patients present with the symptoms of what is called facial plethora, which is basically red puffy skin. You can also find out that aquagenic pruritus when the patient's having unbearable pruritus after a warm bath or a shower. So histamines can be released in this disorder to cause the pruritus, and pruritus is also one of the symptoms of polycythemia vera. Then there is another important association of polycythemia vera with the deep venous thrombosis, because there will be the increase in viscosity of the blood, so you can expect that blood clots etc. in this disorder. And classically, the most important disease which we have to keep in our mind is the Budd-Chiari syndrome, in which there is a thrombosis of the hepatic vein, and it is associated with polycythemia vera. So how you will treat polycythemia vera? Usually by phlebotomy, by taking out the blood from the patient, or administering hydroxyurea. So what is hydroxyurea is doing? It inhibits ribonucleotide reductase and blocks the formation of the deoxynucleotides for DNA, and hence cell can die out. Now the complications of the polycythemia vera, that some of the patient can also progress towards myelofibrosis in a phase known as spent phase. Now spent phase of myeloproliferative disorder is that in time the cells start to die out and lead to fibrosis of the bone marrow. At that point the bone marrow can no longer produce blood cells. So when there is excessive production of these cells, so eventually the bone marrow will get fatigued and can lead towards the fibrosis of the bone marrow. So at that time the bone marrow can no longer produce blood cells, leading to anemia or low RBC counts, thrombocytopenia or low platelet levels, leukopenia or low WBC levels, and this is known as spent phase, in which it eventually becomes fibrosed and cells will start decreasing in number. So, but only minority of the patients in the polycythemia vera, maybe 10 to 15%, go into that spent phase. Polycythemia vera can also convert into leukemia, usually most commonly acute myeloid leukemia, and very rarely also converts into chronic myeloid leukemia. So what will happen that one of the complications of polycythemia vera is also the formation of gout because of excess DNA turnover from the increased red blood cell production. So what will happen when there will be increased red blood cell turnover because of DNA is turning over? So there will be the increase in purine metabolism and increased uric acid will secreted, and hence gout can also be a presenting complaint of the polycythemia vera. Now essential thrombocytosis, as we have discussed, is proliferation predominantly of megakaryocytes or platelets. So it's also a malignant proliferation of the myeloid stem lineages, but predominantly of megakaryocytes or platelets. So what will happen that basically essential thrombocytosis is a diagnosis of exclusion because reactive thrombocytosis or increase in platelet count is also common in many other diseases like iron deficiency anemia, in various infections or metastatic tumors, or maybe in hemolysis. So you will find out that reactive thrombocytosis or increased platelets, for example, most commonly in inflammation you will find the reactive thrombocytosis. So what you have to do is to rule out reactive thrombocytosis is to find out some acute phase reacting tests like C-reactive protein, fibrinogen, ESR, ferritin, etc. So if those levels will be increased, so you can say that it's a reactive thrombocytosis instead of essential thrombocytosis. So it's basically a diagnosis of exclusion. You have to exclude rest of the diagnosis, and if you have excluded that, so you can say that it's an essential thrombocytosis, which is a disorder of myeloid stem lineages. So what will happen that you will have that abnormal platelet function because they will be produced in excess, so they will be abnormal, and you will find a spectrum of bleeding and thrombosis. Both of bleeding and thrombosis can be expected in this essential thrombocytosis. So now we will discuss about the myelofibrosis, and myelofibrosis is basically a fibrosis of the bone marrow. So it's divided into two different disorders. One is the primary myelofibrosis and the other is the secondary myelofibrosis. So primary myelofibrosis is basically a myeloproliferative disorder, and secondary myelofibrosis can emerge out, for example, from polycythemia vera, just like we have discussed the spent phase, chronic leukemia, and other causes in which the primary disease is a different one, but then it is eventually leading towards the fibrosis of the marrow. And then there is a primary myelofibrosis, which is primarily a disease of the bone marrow. So what will happen in the primary myelofibrosis, that you can expect that fibroblast will start excreting or start secreting excess of collagen. So when the excess of collagen is getting deposited inside the bone marrow, so you can expect the marrow fibrosis. So primary myelofibrosis, when it will occur, when there will be an excess collagen from the fibroblast, which will lead towards myelofibrosis. So the point is that how fibroblasts will get activated. So usually the megakaryocytes inside the bone marrow can secrete platelet derived growth factor, which is also called PDGF, or transforming growth factor beta, TGF beta. So what these factors will do, that they will stimulate fibroblast, and by stimulation of the fibroblast the collagen will start secreting, and it can cause the myelofibrosis. So what you will expect, that when primary myelofibrosis there will be a failure of the bone marrow because you are just secreting excess of collagen, which is just like dumping all the cells inside the bone marrow. So what will happen, that just like in thalassemia, if there, for example, thalassemia or any other disease in which there is the disorder of the bone marrow, what starts, extramedullary hematopoiesis will start, because when the bone marrow is not functioning properly, so the other organ will lead and will start secreting the cells like spleen, liver, lymph nodes, CNS, lungs, bladder, or even in skin, you can expect the